LAPACT is quite an important trial. In terms of our treatment of locally advanced pancreatic cancer, we don't have a lot of data for either of the chemo regimens that we currently use, gemcitabine Abraxane or FOLFIRINOX, and this is really the first prospective trial of some of these newer chemo combinations. This obviously was a trial of gemcitabine Abraxane in locally advanced disease, and really the first study that validates the way that we're treating these patients. So because of that, it's a very important trial, and it was nice to see it presented today. When we see the results, the efficacy results from the trial, they look quite impressive. I think it's important to consider that this is a select patient population. So in the locally advanced setting, we see kind of a mix of different performance status. To be eligible for this trial, you had to have very good performance status, ECOG 0 or 1, and you had to have normal liver function, normal bilirubin. So I think the efficacy data is likely a bit better than what we'd see in a real-world setting because it's a highly selected population. That being said, it is in keeping with what we've seen with some other meta-analysis that have been done in this setting with combination chemotherapy. So overall, I think it's in keeping with what we'd expect to see in this type of trial. I think it's difficult to make too much of the response rate in this study because response was investigator assessed. It wasn't done by a central review. That being said, it's in keeping with the response. I think in the MPACT trial, the investigator-assessed response rate was about 30%, so it's similar to what we would see. This is a response of the pancreas mass. Obviously, these patients don't have metastatic disease, and in this setting, ideally, we would hope for patients to be potentially become surgically resectable. I think there's an evolving nature of what we consider borderline resectable versus locally advanced, and I know some patients did go on to have surgery as part of this study. So I think definitely response is an important measure, and so I think what we saw in this trial is kind of what would be expected. So the data presented would suggest about 15% went on to have surgery. I think that it's likely more than that because this is just the amount that went on during the initial part of the study. Again, I think our landscape in treating locally advanced disease is changing very rapidly, and we are where we never used to consider operating on patients in this setting. We are now becoming more aggressive with considering surgery. There's recent data out of the Mass General Hospital in Boston showing a very successful rate of surgical resection even in initially locally advanced disease. So I think the field is changing. We are going to see more movement towards considering surgery in this setting. The amount of chemotherapy these patients receive a lot relates to how well they're tolerating it and what their initial performance status is. So in someone who starts off as a very good performance status and is tolerating the treatment well and having stable disease, then likely they'll receive more chemotherapy. Often it can be as long as a year or even longer. In patients that have more toxicity or progress more rapidly, it's shorter. So a kind of medium of 5 to 6 months, I think, is in line with our expectations. I think as was presented, this was very well tolerated treatment without any new safety signals. I think the caveat when we apply this data to our practice is that this was a very highly selected patient population, and they all had normal liver enzymes, normal bilirubin. If they had a biliary blockage, they needed to have a metal stent. This is not necessarily what we see in practice, and so I think as we use this treatment in practice with people with poor performance status or slight changes in their liver enzymes or bilirubin or possibly a plastic stent, we may see some more toxicity. But I think in any event, it's not out of keeping with what our general practice with the use of gemcitabine Abraxane in the advanced metastatic setting is. I think we know from previous studies in pancreatic cancer that the major driver of a poor quality of life is disease progression, and any treatment that can maintain disease stability or induce a response will be associated with stable or improvements in quality of life. So again, I think that data was not unexpected, but it's nice that it was included as a measure in the study. So again, this is an important study because we don't have a lot of data in this setting. That being said, it's in line with what our practice already is, where we will either choose gemcitabine Abraxane or FOLFIRINOX for good performance status patients with locally advanced disease. But it is very useful to have more data to support that practice.